Hello, Cardiology Update listener and viewers. My name is Chadi Alraies. I'm the Cath Lab Director at Detroit Medical Center. Today I'm going to be coming to you with a summary of the American Heart Association 2023 conference that took place in Philadelphia and came up with a lot of heart failure interventional as well as imaging trials. Let's start with the first one. The first trial is DAPA-MI, and this trial is investigating the other indication for SGLT2 inhibitor. In this trial specifically, they included more than 4,000 patients with non-diabetic as well as no history of heart failure, but they have a CV event or myocardial infarction. These patients received dapagliflozin, which is considered an SGLT2 inhibitor, regardless of their status if they have heart failure or diabetic. So basically, this is a patient who have an ACS event and eventually discharge on SGLT2 inhibitor. The primary outcome was in looking into MI, heart failure, rehospitalization. And sure enough, patient who received SGLT2 inhibitor, which is dapagliflozin in this case, had a lower rate of rehospitalization and heart failure after MI compared to the placebo. This is other kind of indication or other valuable benefit of this medication in patient post-MI, regardless of their ejection fraction or diabetic status. The second trial is a follow-up trial, which is the Orbita-2 trial. This trial looked into patients with a stable ischemic heart disease or patient who have angina, and what is the benefit of revascularization in these patients compared to medical management alone. In these patients, there was, when they randomized to medical therapy, 150 patients in each arm, looking into revascularization based on the stress testing, as well as versus medication. Patients who underwent coronary angiography did receive physiological evaluation by IFR or FFR as well, and patients who ended up having an intervention due to significant FFR measurement did show significant improvement in angina symptoms compared to medication alone. So this is again a step forward that revascularization with coronary intervention beyond medical therapy does improve angina symptoms in patients with a stable angina disease. The third trial is ACLS Shock trial. And this is a very interesting, well-done trial looking into the outcome of patients presented with acute myocardial infarction and cardiogenic shock. As we know, mechanical circulatory support has been controversial in these settings, and there's multiple registry data and retrospective analysis of post-hospitalization data showing some benefit, but there's some complication. However, in this trial that was done really well, ACLS Shock trial, they randomized patients to receive mechanical circulatory support compared to those without mechanical circulatory support for patients presenting with MI and shock. The shocking news is that there is no benefit in MCS or ACLS in patients who received shock, even regardless of the cardiac arrest status. So even if the patient came as a MI shock and cardiac arrest and received MCS or cardiogenic shock due to MI alone, there is no significant difference. Yet there is an increased risk of vascular complications, bleeding, as well as some not statistically significant, but yet trend towards higher stroke rate in patients who receive MCS. So again, in this trial, kind of showing and questioning the value of mechanical circulatory support in patients with acute myocardial infarction and shock. More trials is coming underway. There's a new trials coming currently under evaluation by industry-sponsored companies. But again, based on this well-done trial, I think the trend is towards less of utilization of MCS since it increases the complication with no mortality benefit. Another very important trial is a selected trial that were presented at the American Heart Association, which is looking at the GLP-1 inhibitor, which is the Semaglutide. In this trial, which is very commonly used medication for weight loss as well as diabetic control in patients with diabetes. In this trial, the investigator looked into the value of semaglutide use in patients with no diabetes, but yet they have a BMI more than 27, as well as have a cardiovascular event, patient post-MI, patient post ACS. And the primary endpoint is looking into acute myocardial infarction, heart failure, stroke, and death. And surprisingly, there was a significant improvement and significant benefit in patients who receive semaglutide on weekly basis in terms of reducing their weight as well as reducing their event in terms of cardiovascular event, MI, stroke, as well as cardiovascular death. Sets up some portion of the patient, they have to stop the medication due to the side effect of the medication, mainly GI symptoms. But overall, the study is favorable of continuing semaglutide in patient with cardiovascular event, despite their status of diabetic or non-diabetic, but they have a weight of a BMI more than 27. Again, in summary, I think this is a good indication. Again, it's not FDA approved, but this is a new kind of enlightening findings to show that the patient who have no diabetes but obese and have cardiovascular event, maybe that's going to be one of the regimen we're going to give these patients before discharge after acute myocardial infarction. Next trial is looking into the evaluation of blood pressure management, especially in women, which is called POP-HT trial, which is looking into postpartum hypertension management, whether it's supervised by a physician using Bluetooth devices or by standard of care, which is the patient regimen being prescribed after pregnancy. These patients have either preeclampsia or pregnancy-induced hypertension, and then they monitored after the pregnancy, and there was a significant reduction in systolic and diastolic blood pressure in patients who were monitored by Bluetooth devices in postpartum hypertension. And there was a complement or subgroup analysis, which has an imaging component of this cohort of patients, where they looked into echocardiographic findings as well as MRI finding, looking into the remodeling as well as the LV thickness in patients who have hypertension. And indeed, there was significant improvement in the thickness and hemodynamics, as well as the filling pressure on echocardiogram and MRI in postpartum hypertensive patients who are monitored using Bluetooth devices compared to standard of care. Going back to the shock, also looking specifically at women, there was a registry looking into the outcome of women presented with cardiogenic shock and acute myocardial infarction. Surprisingly, using this registry data, the woman has been subject to less intervention as well as more stage intervention and less of offering therapies such as left ventricular assist devices for advanced heart failure, as well as listed for transplant. This is a very enlightening findings, although disappointing that women are treated differently than men in terms of their referral for intervention or complete revascularization, as well as mechanical circulatory support and LV assisted device in patients with advanced heart failure post-MI. The investigator as well as the presenter suggested that this will strengthen the point that we need to have more trials focus on outcome of women with acute myocardial infarction and shock, or shock in general, and how we treat women differently than men. But overall, there was kind of disparity in care between men and women over a course of the registry data that's presented by the investigator. But also, this is again a signal that women are getting less attention in terms of complete revascularization as well as advanced heart failure therapy after cardiogenic shock. Staying in the heart failure space, there is a trial called ARIES HM3, which is looking into the value of adding aspirin plus anti-vitamin K inhibitors in patients with LVAD. So a patient who usually, as just a remind the audience, is a left ventricular assist device, usually patient were required to be on warfarin with a target INR between 2 to 3 or 2.5 to 3. However, the investigator looked into this trial to see if there's a value of adding aspirin on top of warfarin, which is usually what we do in normal practice. This is a very valid question, and what they looked into to see randomized patients who have LVAD already to be receiving either warfarin alone or warfarin plus aspirin. And sure enough, the patient who received aspirin has more increased risk of bleeding, more increased and similar events in terms of thromboembolic events. The findings of this trial, as well as the investigator, suggested that aspirin might be safely excluded from the regimen in these patients who have LVAD without any increase of thromboembolic events, and yet protecting the patient from more bleeding events. Going to the preventive cardiology space, there was a Heart-1 trial, which is looking into the VERVE-101 gene inhibitor with PCSK9. This is a single-dose inhibitor for PCSK9 and showed a randomized trial, but this is a prelim result looking into the safety and efficacy of this medication. Again, in this trial, there was no clinical outcome or endpoint, what was more focusing on the efficacy and the safety of the medication. But sure enough, at the end of the follow-up, there was almost 80% reduction in the PCSK level, as well as almost 55% reduction in the LDL level in the serum at the end of the follow-up. Again, this trial is still undergoing and in terms of recruiting and looking into more clinical outcomes down the line, but this was a preliminary findings from the trial that were presented at the American Heart Association. Another preventive trial is the REMAIN-2 trial, which is looking into the ricatinlimab PCSK9 inhibitor and 2 different doses, 150 milligrams every 4 weeks, or 300 milligrams every 6 weeks, or 450 milligrams every 12 weeks. And this is kind of studying more of the frequency and effect of that frequency, which is less compared to other PCSK9 inhibitor on the level of LDL. And sure enough, after 24 weeks of follow-up, there was a significant reduction of LDL level compared to placebo as compared to the other in different regimens. But again, this is only looking into the reduction, safety and efficacy of this medication, and there was no clinical outcome or clinical endpoint related to this study. Finally, I would like to thank you for staying with us, and I would like to thank all the Cardiology Update viewers as well as listeners to staying with us to get you all the update from the trials. I am Chadi Alraies from Dein Medical Center. Please stay tuned for more videos coming forward almost every month, updating you on most recent result and trials. Thank you for watching, and Happy New Year.